Hello, good morning, good afternoon, and good evening to all our speakers, shares, and the wonderful audiences in different parts of the world. Welcome to ACNS Webinars. The speaker for the first session of today is our honorable guest from Australia, Professor Antonio Ieva. Professor Antonio is a professor of neurosurgery at the Macquarie University Hospital, Macquarie University, Sydney. He heads the Computational Neurosurgery Lab at the Macquarie Medical School and also the Neuroscience and AI Program Lead. He also serves as a professor of neurosurgery at the Ministry of Education, Universities and Research, Italy, and associate professor of anatomy in the Medical University of Vienna, Austria. He recently organized the world's first computational neurosurgery workshop in Sydney, and we are extremely honored to have him today with us and as a speaker for our webinars, and today we'll be talking about a glimpse in computational neurosurgery. For the second session of today's webinar is our honorable guest from United Kingdom, Dr. Kumar Abhinav. Dr. Kumar is a consultant neurosurgeon, cranial, skull-base, endoscopic and open, pituitary and vascular neurosurgery and spine, Department of Neurological Surgery, Institute of Clinical Neurosciences, South Med Hospital, Bristol, United Kingdom. His clinical interests are focused on complex cranial skull-base surgeries and complex pituitary and cerebrovascular neurosurgeries. He completed his one-year clinical operative fellowship in the open vascular and skull-based neurosurgery under the mentorship of Dr. Gary Steinberg at the Department of Neurosurgery, Stanford University. And following that, he completed a further one-year clinical operative fellowship in skull-base focused on advanced open and endoscopy skull-base under the mentorship of Juan Fernandez Miranda at the Department of Neurosurgery in Stanford. He is passionate about surgical neuroanatomy research and also have a specific research interest in the structural and functional connections of human brain using advanced and white matter imaging techniques. We are extremely honored and grateful to him for accepting our invitation to be a speaker at our webinars, and today he'll be talking about anatomy of foramen, lacerum and Trans-Pterygoid approach. The chair for the first session of today is our honorable faculty from Russia, Dr. Gleb Danilov. Dr. Danilov is a consultant neurosurgeon and statistical programmer at the Burdenko Institute of Medical Sciences, Russia. His clinical expertise is not only focused upon neurosurgery, but he also holds a PhD in data mining and analysis. He is a specialist in statistical computing, neuroimaging analysis, and analytic product development for neurosurgery. He is the head of AI subcommittee of the ACNS and also a noted author with publications in over 60 journals, and also has written around 20 book chapters. We are extremely honored and grateful to him for accepting our invitation to chair the session of Dr. Antonio Ieva. The chair for the second session of today is a distinguished faculty from Taipei, Taiwan, Dr. Wei-Sing Wang. Dr. Wang is an attending staff, Neurological Institute, Department of Neurosurgery at the Taipei Veteran General Hospital, Taiwan. Also an assistant professor in the Department of Neurosurgery at the School of Medicine, National Yangming University, Taiwan. He is the director of the VGHU PMC Endoscopy Skull-Based Cadaveric Dissection course and director of the Taiwan Skull-Based Surgery Society, director of the Taiwan Pituitary Society, director of Taiwan Society of Middle Youth Neurosurgery, and he was a past research fellow at the neurosurgical department at the University of Pittsburgh School of Medicine. His clinical interests are focused upon complex skull-based surgeries, and we are extremely grateful to him for accepting our invitation to chair the session of Dr. Kumar Abhinav. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and our wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Bun Singh from Malaysia is my co-host for today. With that introduction, I would like to hand over this online podium to our first chair, Dr. Gleb Danilov.
Thank you so much, Dr. Kristan Kuti. Thank you, all the participants, and thank you for inviting me and allowing to introduce Dr. Ieva's talk. Actually, Dr. Kristan Kuti has already said a few words about Professor Antonio Ieva. The term computational neurosurgery sounds like magic, at least for most clinicians. So, not to waste time, I want to give a word to Professor Antonio Ieva with his tentative talk. Yes, Antonio Ieva, please, the floor is yours.
Thank you so much for the kind introduction, Gleb, and thank you so much for the invitation. So, in these 40 minutes, I would like to give an introduction on is an overview in computational neurosurgery. As I said, I'm a professor of neurosurgery in Sydney. My main interest is skull-based surgery and neuro-oncology, but I've been working in this field over the last 20 years. And so I would like to show you a little bit an overview of what happened over the last 20 years from the computational modeling to the modern AI. So these are my disclosures. you well know that neurosurgery has many subfields and subspecialties. So where do we put computational neurosurgery? Is this a new subfield? We talk about the what, the why, and the how of computational neurosurgery. So let's start from a definition. Computational neurosurgery is a novel translational field where computational modeling and artificial intelligence are used to improve diagnosis, treatment, and prognosis of patients affected by diseases of neurosurgical relevance. Last year we published a book on computational neurosurgery, and just a few months ago has been also translated in a Chinese version. So you know well the neurosurgical evolution. Consider that from the ancient trephination, from the first experience in the Middle Age, we had to wait 600 years before Yazergil basically introduced all the modern concept of contemporary neurosurgery. So if we know this evolution towards neurosurgery, what about computational neurosurgery? Well, if we ask ChatGPT, this is a computational neurosurgery nowadays, but as you know, we are very, very far from that. Where we are now, I think that is a pattern analysis, and I will explain you this overarching concept. So imagine that this is the figure of the first depiction of a brain. And you can see that there are some depiction of the ventricles, but all the sulci basically are patternless. There is no pattern there, and we had to wait more than 500 years until Rolando, Silvius, they start to talk about the same pattern and the identification of the cortical representation of the brain. So we're going from a patternless to a patterned brain. And of course, nowadays we know that the complexity of the brain is much, much more than that, because the complexity of the brain is not just the sulci and gyri, but is the connectomics. So how the brain is connected and how the functional networks are influenced by pathologies and how we interact with these networks from the neurosurgical point of view. So when we talk about patterns, is imagine that you see the angiogram of the brain, and very, very quickly you can recognize if the normal anatomy of the vascularization of the brain is disrupted, like in arteriovenous malformation, for example, or in an aneurysm. And this is exactly the same pattern extraction from the cognitive point of view. We do when we see trees, we see some trees, it's always the same object, but these are two different trees. So what I'm aiming to is that basically most likely there is a kind of a structural fingerprinting, and this is the pattern of different things in nature. So how we measure a pattern? You surely can use a ruler, but it's very idealistic to use a ruler to quantify the geometrical complexity of natural objects. Let's take this example that comes from my research, one of my first research more than 20 years ago. Here you have the histological slide of a normal pituitary gland, A, and a pituitary neuroendocrine tumor, B. Here we used some immunohistochemistry against the endothelium. So what we see is a CD34 immunostaining the vessels. You already characterize that here there are different patterns, and you don't want to use just the number of the vessels. It's too reductionistic. So at the time, the idea came from a sentence that I read by Ray Kurzweil, saying that the brain does not follow a typical top-down design, rather a probabilistic fractal type of organization to create processes that are not fully predictable, which means that basically fractal geometry introduced by Mandelbrot in the 70s is eventually one of the ways to mathematically demonstrate the complexity of a pattern, so the fractality of nature. And why that? Because if I use this model, the fractal geometry, quantifying the geometrical complexity to the pituitary tumors I showed you before, well, we have an objective quantitator telling you that this is not just more vascularized, but also the geometrical complexity is different. And so we have a mathematical evaluation of what a pattern is, saying that the higher fractal dimension of the vasculature is the gland, and the lower eventually is the tumor. So pattern analysis is a branch of machine learning that focuses on the recognition of patterns and the regularities in data. So this is the first topic, pattern analysis. And the second one is the decision making in neurosurgery. So if you, when I already was publishing the Handbook of Scalpel Surgery more than 10 years ago, I was using a lot of diagrams like this, of course, because we love our diagrams in medicine and neurosurgery. Here is the typical vestibular von Neumann, grade 3 and 4, according to COS, and what happens if there is a bifurcation towards this or that. So we binarize the decision making. So I was trying to understand if machine learning could help in that way. And indeed, in machine learning, there is a decision tree learning in which there is a probabilistic binarization of the decision, which can be computed. So basically, we are putting decision making from the neurosurgical point of view, helped by means of machine learning. So in order to give us some examples, let's start from computational neuro-oncology. This is the typical glioblastoma as we see nowadays. This is before surgery in MRI, and this is after surgery on pathology. But now, if we use digital neuroimaging, we go towards the computational neuroimaging branch here to the left, and towards the computational neuropathology if we digitalize the slide and we start to apply some computational modeling. So one of the examples, putting together the concepts I was talking to you about before. These are gliomas, all immunostained for the macrovessels by means of a CD34. We put these in a random distribution, and we ask the computer to give a kind of order according to the geometrical complexity of the macrovascular network. And this is what happens. The computer puts a kind of order from the lowest geometrical complexity of the vessel to the highest one. And when I asked to a pathologist to interpret what the computer was doing, not by chance we found that the one with the lower complexity were grade WHO grade 2 glioma, and these were grade 3, and these were grade 4, which means that basically the computer, without knowing anything of neuropathology, was able to cluster some features, and these features are meaningful from the clinical and pathological point of view. So this is just an example how you use a computational model to go towards stratification and clustering of features. So I use the same model in also neuroimaging. When I was doing my PhD in Vienna in 2009-11, I was applying the same fractal model also to the SWI patterns in MRI, specifically 7 Tesla MRI. So on 7 Tesla MRI, we can see a lot of things, more than 3 Tesla, of course. And in this case, I was trying to quantify the geometrical complexity of the SWI patterns. By doing that, we were able to quantify the geometrical complexity of macrovascularization and macrobleedings. We were able to see that, for example, this patient scanned every 2 weeks was still increasing the macrovascularization in spite of the use of Avastin. And in this other case, we were even able to recognize different glioma, different types, different grades, grade 2, 3, and 4, exactly in the same way I showed you before in the histopathological analysis. These are gliomas, but we extended the same project also to different kind of tumors. And again, the computer was able to differentiate different kind of tumors. In this case, we have meningioma, metastasis, lymphoma, and glioma. Meaning that basically every kind of tumor has a feature, and this feature can be quantified by means of pattern analysis. Whatever kind of pattern analysis is, the computer is helping us with the differential diagnosis. So if you put together all these features and information, we understand that the fractal patterns can be used to quantify histopathological features, neuroimaging features, and not just in tumors, but also in other applications, as we will see later on. But not just in images analysis, even in time series analysis. So we can use, for example, the same methodology to quantify the complexity of the intracranial pressure over time, or the EEG or magnetoencephalography time series, and so on. Anyway, if you have interest in these, I also published a book called The Fractal Geometry of the Brain, with the first edition in 2015 and the second edition in 2024. Now, we go towards the other field, which is also a field that analyzes patterns. The overarching field of artificial intelligence entails machine learning and the deep learning, which is the most modern part of artificial intelligence. But of course, you know that nowadays there is something more, which is the generative AI, and nowadays we are also already in the time of the agentic AI. So let's apply the concepts of computational modeling, fractal geometry, and AI in brain tumors, for example, because this is an exemplary computer vision-based workflow. You will see application in neuroimaging and some applications in the digital neuropathology. So starting from neuroimaging, you may know that we have a challenge every year with the best algorithm to predict the segmentation of tumors, of glioma and the other tumors. So the ground truth is what experts delineate in terms of edges of the tumor, necrotic part, and the edema. And we look for algorithms doing basically the same job of experts. And this is the prediction, which is quantified by means of different metrics, for example, the DICE score. So these are just some representation of our studies over our contribution over the last 7-8 years, how we segment in automatic way all the kind of brain tumors. And nowadays we go also towards what we call few-shot learning, in which basically we try to reduce the size of the training data set in order to have still a very high accuracy. And this is another kind of a project we did on the meta transfer learning for segmentation. Now, why we need the segmentation? Why it has to be so good? Of course, as a neurosurgeon, we might think that it's just for volumetric analysis. We want to know the size and the volume of the tumor. But actually, it's much, much more than that. The real application nowadays is radiomics, because you want to apply and deploy a pipeline in which you are able to extract mathematical features at the voxel level of each single slice and each single region of interest. So the region of interest in this case is the tumor, and that's why it is so important to have a perfect segmentation, because we want a radiomics feature of the tumor or of the peritumoral area or of the brain. And why we do that? Because by extracting radiomic features, which are quantitative features, we can put together the first, second, and third higher order statistical features, and use some machine learning, like for example support vector machine or random forest, in order to have a clustering which goes towards differential diagnosis or even survival prediction. And I will show you some examples. So basically radiomics, after the segmentations, helps for automatic classification and for enhancement of the differential diagnosis. And maybe we are even going towards the survival prediction, which can be used for clinical purposes. Now, this is the pipeline that we have established at my lab over the last 10 years. So every tumor coming at my university for treatment, basically we have the images, there is a pre-processing, we have a manual segmentation, we have a deep learning based segmentation, and when we have done that, everything goes towards radiomics, deep learning, and everything is used for prediction of the diagnosis and eventually even of the survival. And this is an example of the pipeline in which the tumor, automatically segmented, goes towards a task. In this case, there is just an example of the prediction of the MGMT methylation, if it is present or absent, and this accuracy can be even increased by adding some clinical information like age, gender, and presentation of the clinical features. So last year we published this systematic review on the diagnostic performance of deep learning for predicting glioma, IDH, and the 1p19q co-deletion, just at the MRI level, so even before we do the surgical sampling. And as you can see, the prediction is relatively high, 80%, the sensitivity is 85%, sorry, 80% is the sensitivity, and 85% is the specificity for predicting the IDH mutational status just at the MRI level. And the 1p19q is slightly lower. Now, this number could be increased over time, but the real problem comes from different papers, is related to the segmentation heterogeneity, and that's why it's very, very important to have a perfect segmentation, and by the integration of different deep learning methodology, which means that this number can increase when we create a pipeline which is more standardized at the world level by means of federated learning, for example. Now, what about the digital pathology? We spoke about the neuroimaging. Let's go a little bit more digital pathology. Nowadays, this is how it works. We have the sample, we send it to pathology, they do H&E staining, immunohistochemistry, and of course genomic sequencing and other tests. And at the end, they give us the integrated diagnosis, which is still related, first of all, from feature extraction. Here is the pathology telling you which feature is more important. And after that, we go towards the tiers by tiers to other analysis. So how we integrate this cognitive process in a computational model? Well, before we spoke about radiomics, now let's talk about the pathomics. We can digitalize the slide at a very, very high resolution, so we can have a very high resolution to see at pixel level each single micron on the slide. And we can do some heat maps of features. These features could be the similar one to the radiomics, the pathomics one, or we can use deep learning for creation of some whole slide image analysis in order to have an automatic prediction, classification, and even prognostication sometimes. Example, here you see H&E glioma. Every one of you guys and every pathologist in the world knows that these are glioma, but no pathologist can tell you if there is an IDH mutation here or not. And why? Because or you need the immunohistochemistry, or eventually you have to go towards genetic sequencing. And this takes some time, some money, especially for genetic sequencing. So the idea, and this is already an idea going back to 7 years ago, was training a deep learning model to understand and to check whether the model was able to recognize the mutational status even just by from this slide without doing any further test. So basically we had a training data set of IDH wild type glioma, another one with the IDH mutant glioma. We trained a deep learning model, in this case was a ResNet 50, and we had a pretty high accuracy, almost 85%, to predict, according just to the HE immunostaining, if the tumor of that patient was wild type or mutant. Now, 85% sounds very, very high, but is still far from the gold standard of pathology, which is 100%. So how could we increase that accuracy? Well, the real problem was not the model itself, but was the dataset size. Because you know that if Google is so good to recognize cats and dogs, it's simply because it's been trained on millions of different cats and dogs. Millions are not numbers that we have in cancer in general, in glioblastoma. So the idea was generating synthetic images. Let's increase the size of the dataset, creating some new images. And this was the first use in digital pathology of a GAN, which is a generative adversarial network, to augment the dataset. So here you can see the algorithm that basically is generating new images of glioma. So the image original dataset of 900 cases was enhanced to 3, 4, 5, 6,000 of synthetic gliomas. And this synthetic dataset was used by means of reinforced learning to retrain the model and to see if the accuracy was increasing. And by doing that, 85% became more than almost 95%, which is much, much higher. And this is a publication of 6 years ago, actually. But nowadays we can even increase the accuracy to 97 to 98%. We can do something more with the diffusion model for synthetic images. We have the transformers, which we did not have in that time. So to make the story short, we are almost going towards the gold standard, which means that in the future, we can just doing a simple staining of a slide during a surgery. And already in almost real time, we can have the information even before doing all the chart of doing the immunostaining and eventually the genetic sequencing for the mutational status. So what about when we go to theater? Because these are all research tools, let's be honest, the research tool to be applied before surgery in neuroimaging and during and after surgery with the digital pathology. But what if we want to do something during surgery? So you may know that one of the use of the last years in neurosurgery is the Raman spectroscopy. So basically, we shine some laser on the tumor on the brain, and the scattering of the light coming back gives us to the emergency of a spectroscopic fingerprinting, which can be analyzed and can be analyzed by means of machine learning, and this can be used for clustering. So in this case, in this paper published many years ago from a Canadian group, they were saying that these are the fingerprinting of the normal brain, infiltrated brain, and cancer. So one of the works we have done over the last years is the use, for example, of this kind of fingerprinting in the fluorescence-guided neurosurgery. We know that if you use 5LA, the tumor shines up in pink, and this is amazing because you can follow the pink, although you should not follow the pink dogmatically because, as you know, not always is cancer. But the point here is that the pinkness, let's put it this way, is related to our filter that we use in the microscope and our capacity to recognize this kind of a wavelength. But there are many other frequencies that we are not able to see. So the idea nowadays is creating a kind of a multispectroscopic fingerprinting in which we have a hyperspectral information which can be analyzed by means of deep learning. So this is in this slide there are just the summaries of a couple of papers, so you can read this paper if you're interested, in which basically by using 5LA in tumor in brain cancer surgery, we were trying to extract the spectroscopic fingerprinting and doing a deep learning based hyperspectral image analysis in order to have a clustering. And as you can see in this slide, basically we had a very good clustering of a different kind of tumors and different kind of infiltration in the brain, which means that basically, although these are still kind of research tools, in the future we can have a kind of a smart microscope giving us this information in real time according to the scattering of light and according to the summarized information by deep learning, giving us some very meaningful information in real time during surgery. So let's go to another topic because, as I told you, I want to give you a glimpse, kind of overview of computational neurosurgery. There are many other applications. So here is a supraorbital eyebrow approach did a few years ago, and as you can see in this video, we are going towards the end of the resection. There is still a bit of a remnant here and here. As an expert, you can recognize all the anatomical features. And here there is the microscopic visualization, and here is the endoscopic visualization. Because in general, I always use endoscope or microscope-assisted neurosurgery, and that's the remnant of the tumor. So can deep learning help us to recognize this structure and eventually emphasize a remnant of the tumor or anatomical features which are important in a surgical perspective? So one of the studies we've done is doing exactly that, and this is the typical deep learning model in which we have the multimodal imaging of microscope imaging with the endoscopic images, and the deep learning model has been trained to give you a probabilistic map of what could be what. So here 90% we have a gyrus rectus, most likely 80% almost this is the anterior clinoid process, this is optic nerve almost for sure, almost 100%, and there is a 75% probability this is the tumor. So if we can have this implementation in real time, this is really a help that you have during surgery. Now this kind of video is a little bit complex, so there are many features that we're still working on that, but the study we started with was much easier because we always try to start with a simple model in order to tune up the model, to fix problems, and to keep going. So at the beginning, we did a model which was much more simple. We developed a ground truth for a convolutional neural network analysis of endoscopic ear surgical videos. We use that because basically when ENT they do middle ear surgery, they just need 3-4 anatomical structures, and in this case in green the stapes, in blue the chorda tympani, and in yellow the facial nerve. We did at that time an automatic segmentation for labeling, and we used a UNet convolutional neural network to train the machine. So this is the binarization of the images, and this is the result. So this puts all of us a little bit out of our comfort zone because as a neurosurgeon we don't do much of a middle ear surgery. So this, in this case, for example, is just to tell you that there are some anatomical structures that eventually, if you are not really expert of, you might not be able to recognize. But if you add the augmentation of the deep learning based augmentation, this is what happens. So you have the automatic coloration in real time of the 3 anatomical structures I was talking about. So nowadays we are going much forward to this. We are adding also the surgical instruments going in and out, and we are going towards the pathology and the normal anatomy, and these can be implemented in real time. There is a lot of demonstration that this is very useful in laparoscopic surgery, so why not in skull-based surgery? Why not in neuro-oncology? So eventually this is the future of computational neurosurgery in surgery, during surgery, the video endoscopy deep learning-based surgery. So as a neurosurgeon, it helps a lot to have some cases. And now I show you some cases from my own case series and how I use all this computational neurosurgery concept. In case one, you can see the typical tumor. Most likely, this is a low-grade glioma in the middle frontal gyrus of the right side. So, of course, I have my interpretation, but I also do all the pipeline I was talking to you about before. So, deep learning-based segmentation of the tumor segments in green the lesion itself, and already tells me that in green, in red, there are some radiomics features which could flag something else. Anyway, we apply on this automatic segmentation the radiomics. So we use a pararadiomics setting. There is a lot of pre-processing, which has been standardized and automatized nowadays, but it's still pretty challenging. We do a feature extraction. In this kind of a specific paper we published, we extracted 788 radiomics features, and we used 3 different machine learning models, random forest, support vector machine, and multi-layer perceptron, to have a classification of what is what. So we applied that. After that, the same tumor undergoes magnetic resonance spectroscopy. So here we have the typical Hunter curve telling you that yes, it's a tumor, because as you can see, NNA is very low and the choline and creatinine very high. But this is not enough. We do something more nowadays. We do also something much higher resolution. We apply the 2-alpha-hydroxyglutarate magnetic resonance spectroscopy. By doing that at 2.2 part per million peak, we can see that there is a very high concentration of 2Hg. So we can already predict at MRI level that if 2-alpha-hydroxyglutarate is very high, this means that this is not just a glioma, but potentially is also an IDH mutant, because this is the oncometabolite generated by the IDH mutation, which goes towards the oncogenesis of the low-grade glioma. So we already have another information. Nowadays, we try also to use machine learning to put together all this kind of metabolic fingerprinting. I use also connectomics. There are many programs to use connectomics. This is one of those. In this specific case, is omniscient. So we use a resting state of MRI and the DTI before surgery, and I want to see really the networks involved by the tumor and how much can I be supramaximal, if I can be supramaximal, in order to not give a new deficit. So I see the structural network, I do my surgery, and in this case, we had a postoperative volumetric analysis showing a supramaximal resection of 120% of resection. So we removed the tumor flare, but also 20% more, and the patient had no postoperative deficit. The pathology, this is the slides. The pathologist, after a few weeks, told us that this was an astrocytoma, IDH mutant, grade 3, IDH1 positive, ATRX lost on immunohistochemistry, and there was no loss of the CDK2NA2B. Now, if you see the prediction that we did even before surgery, just on AI of the MRI, we already knew that it was a tumor, of course, almost 100%, that almost surely was a glioma, that most likely was an astrocytoma, 93%, and oligodendroglioma was very low chance, less than 60%. That most likely was a grade 2-3 with accuracy of 90%, and that most likely was an IDH mutant, and the most likely was not 1p19q. So this means that all this information that we had on the gold standard were already predicted even before surgery. So this research tool is really becoming something clinical relevant, because nowadays, even before I do surgery, I can consult the clinic, the patient, and my MDT meeting with all this information. This case is even more interesting. This is a woman who underwent 10 years ago a subtotal resection of a low-grade glioma, and every year there was clearly a remnant, and this remnant, of course, was growing in terms of recurrence. And I saw this patient, she was sent to me for a second opinion after 10 years, just showing that every year the glioma basically was coming back, as they usually do. So I did my typical pre-imaging pipeline with MRI, FET-PET, connectomics to see everything. And the strange thing here in connectomics, I saw that the frontal lateral tract was interrupted, although the patient was talking normally. So what does it mean? That basically, or there is an artifact because the edema or the tumor disrupt the signal to see the TTI of the fat, or the tumor or the surgery or the surgeon had disrupted that, but in spite of that, the language was still intact. Anyway, this is one of the cases in which I trust imaging, but not that much. So in this case, I do also awake surgery, of course. I want to interrogate the networks to be sure that I don't give, for example, a supplementary motor area syndrome. So I did the surgery, and I aimed to do a supramaximal resection. As you can see at the end of the resection, my navigation was more medial, more anterior, more posterior, and more lateral. And I achieved what is a supramaximal resection. The patient was put asleep, she was talking and moving, she was put asleep, and the motor evocative potentials were absolutely normal. So there was no dysfunction even in terms of motor function. But and the day after, I had the supramaximal resection of almost 120% of the surgical cavity. Now, the surprise was that the patient woke up actually with the supplementary motor syndrome. She had a mutism and she could not move one side, which was hemihypokinesia. Which was a little bit of a surprise because everything went perfectly during surgery, although you well know that SMA is pretty common in this area. The point is that I had done connectomics before surgery and I did it again the day after. So here you can see the sensory motor network, and you see that the surgical cavity goes very, very close to the corticospinal tract and to the sensory motor network, but it does not destroy it. The same with the silencing network, which is a cognitive network, in which you can see that the surgical cavity goes very, very posteriorly, maybe pruning some small hubs of the network. But the network, all the network is pretty resilient, so did not fall down. And the language, even more important, you can see that the surgical cavity went all the way down, pruning some small hubs of the network, but the network was still intact. This is a very qualitative images, but it can be done also in a quantitative fashion. So this is a pairwise matrix in which you compare that patient connectomics with the normal population connectomics, and we know that there was a bit disrupted by the tumor, but this is the connectomics before surgery and after surgery, and actually was exactly the same. So when I saw that, and this is a lot of machine learning, of course, this is not just this kind of analysis is machine learning based. So when I saw this, basically I was able to tell the patient already the day after, this is a matter of hours or days, but as many times happens, you will recover your function, your language, and your motor skills 100% because the network is still there. So that's the time that I introduced the concept of prognostic connectomics, which means if the patient has a deficit, but the connectome is still intact, is still exactly like before surgery, you can reassure the patient and yourself that there is no deficit. But if the connectome has been disrupted, most likely that deficit will be permanent. Of course, there are exceptions, there is the neuroplasticity, and over time things can change, but prognostically is a worst case. So this is the use of machine learning in connectomics also for prognostication. Just to let you know that I do these things also under ultrasound guidance, and this is, for example, merging all these tools all together. It's very, very useful to try to correct the midline shift by means of ultrasound. And here on this neural navigation system, I basically had the preoperative connectomics merged with the intraoperative ultrasound to see time by time how things might change, how much you have resected, how much more you are aiming to resect. Now, I'm talking about the tumors, but this is just because for sake of time, but you could apply this to everything in neurosurgery. This is a study I did many, many years ago. I called it fractal arteriosvenous malformation because also the AVM are a tangle of vessels in which basically you have a disruption of the normal architecture of vessels. So we did some models years ago to use manual segmentation, machine learning based segmentation, spectral segmentation to have an automatic recognition of the nidus. When you have that, you can start to recognize features. We are not talking about the size of the nidus anymore, like the Martin-Spetzler classification system. We are talking about the geometrical complexity, which is a feature which has been added also by Lawton in his classification system. compactness against diffuseness can be quantified by means of a mathematical modeling to tell you how much complexity is at the edge of the nidus itself. And this is not trivial, because what we were able to show is that the AVMs undergoing gamma knife radiosurgery, which have a lower geometrical complexity, have a much higher chance to have a complete obliteration 2-3 years after the gamma knife itself. But if there is a higher geometrical complexity of the nidus, which is what Lawton calls very high diffuseness, well, this AVM has a lower chance to have a complete obliteration, which means that you can already prognostically stratify these patients can undergo only gamma knife eventually, but this patient eventually need a multimodal treatment, which can be surgery followed by radiosurgery and or embolization. So this is a kind of imaging-based modeling to have some kind of decision-making improvement. Now, talking about the prognosis, we survived basically the survival prediction in brain tumors only on neuroimaging. So you see the MRI. Is AI good enough to prognosticate the life of patients, for example? And well, we are not there. The accuracy is very, very low nowadays. It's in the range of 60 to 70%. But the real problem here, imagine a time in which large language models, multi-agentic AI can increase and skyrocket this accuracy, and we can reach almost 98 to 100% of accuracy in prognosticate the life of patients. So this is really an important ethical question, how we sell this information to the family, to the patients, to the insurance. So this triggered a chapter in my book, which was called The Declaration of Computational Neurosurgery, in which we put together people to try to understand what are the ethical principles we should abide to when we apply AI to neurosurgery. But this was just a kind of a chapter in the book. After that, we tried to escalate to a higher level. So as I mentioned at the beginning, I organized the first World Conference of Computational Neurosurgery in February in 26 here in Sydney. And the third day of the conference, we put together a task force to draft what we called the Declaration of Sydney on the ethical use of artificial intelligence in neurosurgery. So if you're interested, you can scan the QR code here. You can read the 15 articles drafted by the task force, and you have also the chance to sign it. There is still the chance that you can be signatories of the Declaration of Sydney. So in summary, AI neuro-oncology you can use for computer vision of pre, intra, and post-operative neuroimaging, and both in neuroimaging and in neuropathology. You can use radiomics, anatomics, and pathomics. And of course, you can integrate it with the multi-omics approach, like genomics and the metabolomics and so on. Robotics, of course, we haven't spoke about that a lot, but there is the robotic aspect as well. And last but not least, what happens after surgery or before the decision-making of surgery? Well, the MDT. Remember that nowadays it's very, very rare that I bring a tumor to theater with my own decision-making. I always ask to the MDT. But the MDT has also some gaps, some problems sometimes, which are many, many times related to wrong differential diagnosis. So the MDT of the future could be implemented, augmented by the use of AI, because AI could summarize information and increase our accuracy. And that's why in this paper published in The Lancet, I said that basically machines will not replace physicians, but physicians using AI will soon replace those not using it. And this is a sentence I wrote 7 years ago, so it's becoming more and more realistic nowadays. To do that, you have to understand deep learning, but of course, everyone does his own job. So that's why you need a multidisciplinary team of experts from engineers, mathematicians, putting all together and converging in this new field, which is also the reason why I created a new fellowship. The CNS fellowship is for a neurosurgeon coming to my lab for one year and learning how to apply AI to neurosurgery. So in conclusion, learn AI, don't fear it, and use it properly in neurosurgery, because knowledge is power, yes, but I would add that translational science is even more powerful. So that's why we have to put together different kind of scientists. And that's the reason why I created a multi-translational scientist lab called the Computational Neurosurgery Lab at Macquarie University Hospital in Sydney. This is what we did the last year in Boston, the computational neurosurgery session, because really there is a ripple effect of this computational neurosurgery. And indeed, in a couple of weeks in San Antonio. We are repeating the same session if you are interested, and if you are in Texas at the WNS in May. So with this, I can conclude, and I'm ready for questions, if any. Thank you so much.
Thank you so much, Professor Ieva, for a wonderful or excellent presentation and your deep insight into the application of computational technologies in neurosurgery. And you presented an interesting perspective of brain, a model of brain based on patterns. That's what you started from. It's not just a theoretical concept, it's supported by your remarkable work. And today, the rapid development of computational technologies cannot be ignored, of course. We are witnessing the emergence of a new generation of neurosurgeons who are already using AI and exploring the possibilities of applying new technologies in the diagnosis and treatment of brain diseases. Some doctors are even writing their own software, with generative AI, and we're deploying powerful models in our clinics as well. So we're living in an exciting time. However, it's important to remember that science is based on measurements, and computation is a natural consequence of measurements in science. So what Professor Ieva is doing is not just medical informatics or machine learning modeling. It's a real application of mathematics to solve computational problems, which are numerous. I'm particularly interested in your ideas about fractal analysis. Our laboratory has found that fractal dimensions are highly informative for machine learning models. However, as a chair, I would like to ask you a few questions and give that possibility to our other participants. So we have encountered a significant challenge in radiomics because of the poor standardization and low reproducibility of radiomic features of neuroimaging biomarkers. And what are your thoughts on application of radiomics in neurosurgery? Do you believe that we can overcome these limitations? I mean, a poor standardization and a poor reproducibility. That's my first question.
Now, that's an amazing question, because I've been working on this for many years to find an answer. And at the beginning, I had really the optimism to find 1, 2, 3 parameters to quantify everything. And I was over enthusiastic during my PhD of the fractal dimension that you mentioned. And I did many papers only on the use of fractal dimension and locumnarity, for example. But the more you use one parameter, and when you start to see that it fails to classify, you realize that the one parameter is never enough. So you need a bunch of parameters, and these parameters, of course, they become more and more multidimensional when you start to use even more techniques. So radiomics, for example, is based on hundreds and hundreds of different features. So the real problem, number one, is which radiomics feature should be identified, including the fractal radiomics parameters. And the second, when you identified which ones, how you merge a combination of these ones. For example, I used in the past a lot the PCA in order to try to find which features were more contributive to the final accuracy. Now, there is a lot of machine learning exactly to understand that kind of problems. Number one, you cannot really love 1 or 2 parameters. You have to try to give to the machine the possibility to find the best features and the vectors in order to have the best classification. But in order to get there, you mentioned the problem of standardization, and that's the real problem. Because many times when you read the papers in this field, there is a lot of a comparison of apples and oranges. And why? Because the pre-processing parameters were not standardized at all. So many times you do same model, same radiomic feature extraction on a pre-processing which was completely different. And this gives a kind of output which is completely messy. And that's the typical garbage in, garbage out. Because if you haven't done a very nice cleaning of the data, a very nice standardization in the pre-processing phase, it's useless to apply the best model ever, because you will get meaningless data at the end of the day. So that's why the pipeline is to include beautiful data, very well labeled eventually, especially in medicine and in neurosurgery. Very nice standardized pre-processing, and after that we can go to the pipeline from the machine learning or deep learning point of view. So there is really a workflow which has to be standardized with the help of engineers, mathematicians. And as you said, there is a lot of maths here. It's good and beautiful if we understand it. Of course, we don't have to, because we work in teams helping us to fill this gap or that gap in order to have a collaborative outcome at the end.
Thank you so much. And one more question. I would like to know about the conditions necessary for the development of computational neurosurgery, for propagating it worldwide, as it requires the expertise of neurosurgeons, but not only neurosurgeons, mathematicians, programmers, engineers, and you name it. So what are your thoughts on that?
Yeah, well, that's this problem was triggering the creation of the first computational neurosurgery lab in the world, because I had a similar lab when I was in Vienna, but it was much smaller, because I was working with the mathematicians and engineers to apply fractal geometry to neurosurgery, and I really needed their help. When I created the first computational neurosurgery lab at Macquarie in 2018, the problem was the same. I was trying to use machine learning and deep learning in neurosurgery, but I needed the help of engineers, mathematicians, computer scientists, statisticians, and so on. And all these people, the idea was really putting all these people under the same umbrella, and is a beautiful kind of collaboration, because there is not hierarchical at all. There is the professor of neurosurgery learning from the student of computer science, and the other way around. There is a professor of computer science learning day by day from a student or registrar in neurosurgery. By doing that, everyone learns. It's really a continuous teach and learn. And by doing that, you see that there is a kind of also common language. It's beautiful when I hear computer scientists using the right terminology of neuro-oncology, for example. People, some of them, they didn't know anything about biomarkers in neuro-oncology. And nowadays, when I hear them presenting something, it's just amazing. And the other way around, the new computational neurosurgeon coming here after 6-12 months is able to code, to use some library, and to do even some code and pseudocoding, and all these goes towards publication, patents, grant proposal, and application in patients. So it's a continuous teaching and learning process which absolutely requires the collaboration of different experts.
Thank you so much for your wonderful talk and for answering all the questions. And maybe someone in the audience would like to ask questions.
There is only one question which I have answered live. Can AI identify structures during surgery anatomically and pathologically? I have given the link of our previous AI webinars where one of our participants presented this real intraoperative navigation using AI. So you can have a look at that.
Yeah, so I just showed some example. One could be simply based on deep learning of recognition of different structures, like the example I showed, anatomy versus pathology. But you need a training data set in order to ask the software injected in the computer to tell you what is what. So that's the first level. The second level is recognizing some features like spectroscopic features. Of course, in order to see spectroscopic feature, you need a specific machine or giving a light like laser Raman spectroscopy, or other kind of excitation of the wavelength in order to get back a light that most likely you are not able to see. And when the machine has depicted that the wavelength, the deep learning model in real time might tell you if you are on the tumor, on the necrotic part of the tumor, on the infiltrated brain, or in the brain itself. And last but not least, if you are getting the sample out, you know that many labs, many hospitals in the world, they have even the pathology very close to the theater, and they can do in real time a staining, a coloration with the HND and so on. So if you have the chance to digitalize in real time that sample, and that digitalized imaging goes in the pipeline I just showed you before, most likely you can get in a few minutes even the final diagnosis and even the genetic prediction of which biomarker is present in the sample you are sampling. So yeah, there are different tools. Many of these are still research-based. Others are already applied in some machines sold around the world, but this will become more and more normal in the next decades, I guess.
Right. Thank you very much. We had a really wonderful session. Gleb, would you like to close this?
Yes,
Thank
I
you very
just
much.
wanted to say a great thank you to Professor Ieva, for ACNS Organizational Committee for inviting Professor Ieva. It was a great pleasure. Thank you.
Thank you so much.
Thank you very much. So I'd like to mention that we broadcast this on WeChat, YouTube, and Zoom. And as of now, we have around 250 people who have logged into all the different channels. Thanks to Professor Shubin for helping us to do that. Now we'll move on to the second session. I understand it is very late in Australia, but we would love to have you. Anyway, it's your choice, Prof. Diva. We'll move on to the second session, and I would hand this podium over to Wei Sin Wang to say a short introduction and invite Dr. Kumar for his lecture.
Hello, everyone. My name is Wei Sin Wang from Taiwan. It's really my honor to join this ACN's webinar tonight. I would like to introduce the second speaker, Dr. Kumar Abhinav. Actually, Kumar is my good friend. Kumar is from Bristol, UK, and he is a well-trained skull-based surgeon and has a lot of publication. Actually, we met together each other in Pittsburgh more than 10 years ago in a skull-based lab there, and our mentor is Dr. Fernando Miranda's. We enjoy a lot of the skull-based learning the time, and today I think that Kumar will give us a talk about the surgical anatomy of foramen lacerum and the Trans-Pterygoid approach. It probably is one of our project we learn together and from zero to build up some knowledge there. So let me give the time to the Kumar to give us a talk tonight. Kumar, please.
Thank you for the invitation and the Asian CNS. And yeah, I mean, really, Wei Sin, you should be giving this talk as Wei Sin did this project as we've known each other for a long time, meet in international conferences, and, you know, did a phenomenal project on foramen lacerum, which I will be showing some of the examples from that paper that Wei Sin put together with a lot of hard work in the laboratory. And so my focus today, I'm just going to share the screen. This talk was, about foramen lacerum, but I think the main idea today was, I was going to cover foramen lacerum in relation to surgical anatomy and in relation to how this links to understanding the clivus and a more sort of a clinical application, not just as an anatomist, but also as a surgeon working in this area. So as you know, my name is Kumar Abhinav, and as I say, I'm in Bristol, and my main focus is skull-based, vascular, and pituitary, particularly complex cranial work. And we also run a lab, an anatomical lab, focused on advancing this sort of work in Bristol, and run a course along these lines as well yearly, which I can tell you guys about. So why do we need trans-pterygoid approach? It's an interesting question, particularly for a lot of neurosurgeons who are not familiar with the coronal plane work. A lot of work has been done on this by groups quite some time ago in Pittsburgh. Ricardo Corrao and co, they've written several papers on this. So where I use this commonly is complex pituitary adenomas. So when you have cavernous sinus invasion, particularly in certain compartments like inferior compartment, posterior compartment. So it's a useful adjunct for those approaches. Obviously, your classic CSF leak cases in the lateral recess, pathology in the pterygopalatine infratemporal fossa, so trigeminal schwannomas, and I'll try and show some examples, and also the skull-based sarcomas, so chordomas, chondrosarcomas. Having this skill up your sleeve is useful. Rarely we would use this for a petroglyphal meningioma or a recurrent case. And the aim really today is to explain the sort of foramen lacerum as a gateway to understanding the clival anatomy and planning your surgical approaches in relation to the foramen lacerum, whether you're working above or below. So when we think about the approaches, this is, one of my lab fellows working on the orbital anatomy. When we think about these approaches, we are always thinking about them from an open perspective. We are thinking about this in your traditional open classification. And it's also tricky when you go up the nose, and you may or may not be familiar with this anatomy, to translate this anatomy to an endoscopic or a ventral skull-base anatomy coming through the nose. So we know here is the foramen lacerum. When we look through the open view, you can see that the sixth nerve is here, V1, V2, and they've been cut in order to expose the foramen lacerum. So although you work in the cavernous sinus coming from lateral to medial, by and large, most of my cavernous sinus work now is medial to lateral through the endoscopic approach. So here's one of my long papers. As Wayson said, I spent 2 years in the laboratory at Pittsburgh before doing my clinical fellowships. And one of the papers we did a long time ago was this cavernous sinus compartment paper. And here you can see at that stage, the understanding wasn't at the level it is now, but there is your foramen lacerum again. And the idea here is that, the pterygoid is here. This is your Vidian nerve. And the idea here was, when we are accessing lesions around the carotid artery and the foramen lacerum, either below and even going above the foramen lacerum. So this is your so-called inferior compartment. Posterior compartment is behind there. That the Trans-Pterygoid approach gives you an optimal gateway there. And then you have to modify that approach depending upon where exactly you need to go. So my message is, when you look at pathology, you think about it in relation to the lacerum and Vidian nerve, and then you can plan your approach with this epicenter in mind and exactly what you need, because no single approach, it's not a sort of a formulaic method. You have to work out what you need case by case. So for example, this is in a dissection specimen, again from those times. You can see the dural envelope around the carotid artery on the left-hand side, V2, V3, that's the middle fossa dura. And again, why would we want to come there? So sometimes when we have a lateral recess leak, you need to come here, repair the leak. This is with the dural envelope opened, and you can see the petrous apex here, the sixth nerve there, and the foramen lacerum more inferiorly. So if we want to understand the area and the approach, you have to understand the bone. I think some of these pictures, again, were done in the lab when we were in UPMC, and we shared these pictures, and you have to understand the bony anatomy. So these are 3D, but we will go through it in a 2D fashion. That's your sphenoid bone. And we are trying to reconstruct the foramen lacerum coming in open. So, you have your sphenoid bone, you have your clival bone here, petrous bone. And so you think about your natural fissure lines that come to the foramen lacerum. So your petroclival fissure, you're thinking about your petrosphenoidal fissure coming this way. But these are obviously the lines you're thinking of from an open approach. Whereas when we go endonasally, you have to think about it in a different way. This again is your petroclival fissure here. But when we go through the nose, you don't see this view because you've got bones obstructing that view. And that's where you've got the sphenoid bone. And here is your medial pterygoid that you have to deal with in order to work your way back to the lacerum and to the sublacerum zone. So this is your Vidian nerve. Here is your V2. So again, we need to understand this anatomy and to how we deal with that in order to go there. This is my maxillary palatine bone, and again, this is an important bone that is a gateway to that area. So if we think about how to do the Trans-Pterygoid approach, that's the first question. And the second question is to establish the need for it and knowing the indication. So that's a maxillary bone. And let's show you some case examples. So this is a very old picture here, for example, from one of Carau's lecture. You can see these lines that they came up with. This is the sort of axis you get. So here's your medial maxillectomy. This is your medial pterygoid. This is your lateral pterygoid. Here's your Vidian nerve. And that's your foramen rotundum. And what we are trying to do as neurosurgeons often, there's a lot of confusion with this anatomy. When you're looking at the pterygoid plates, there's this term called the pterygoid wedge, which is, a non-anatomical, but albeit coined by Amin Qassam, because the idea was that you have to deal with this pterygoid wedge in order to get into the foramen lacerum and in order to get to the area underneath it. So oftentimes I'll have ENT starting my operation, getting into the maxilla, exposing the back wall of the PPF, and then we find the vidian and I work our way forward. So I'll demonstrate this using some surgical examples. Before we go there, the idea is that it's important to think about the trans-pterygoid approach, but think about it in relation to the clivus and your axis where you're going. So when we are typically thinking about clivus, just to sidestep slightly, here's your upper, clivus or the dorsum. When you're thinking endonasally, this is your mid clivus, where you're going to the floor of the sphenoid sinus, from the lower end of the dorsum, and then you have your inferior clivus, So, and then this is a more useful way of thinking about the area, because then you can plan your approaches. This is JFM work from Stanford, and you can see there is we'll talk about this in relation to the Lacerum paper by Wei Sin, but in effect, when we are planning our approaches, we are thinking, are we going here to the upper clivus? Are we going to the mid? Are we going below? So for the upper clivus, obviously, as you can see, the foramen lacerum is not so important because you really need this exposure. However, if you're doing a mid-clival approach or an inferior clival approach, or you're doing an approach where you need to get around the ICA, a complex adenoma affecting this compartment around the cavernous sinus, or you're trying to go here, you can see why you need to understand the lacerum, because you need that control, you need that understanding of the ICA. So here is your sympathetic trunk, more relevant anatomy, paraclival ICA, that's your sixth nerve in the back, meningohypophyseal trunk, and this is your palaeovaginal, which is a nice landmark when we're doing these approaches to find the vidian. Not coming from the front, here's your choanal arch, you can push that down, find the palaeovaginal, and above and lateral you find your vidian nerve. And that there is your, obviously your V2. So let's look at that. So that's your mid-clival, clivus, obviously. So let's talk a little bit about the upper clivus before we go to the next area, because it's all continuous, it's all relevant. When you're trying to go to the area behind the upper clivus, really you're trying to get into the interpeduncular cistern. And if your gland is not working, it's easy, you can resect the gland and get there. If the gland is working, then you have to think about transposition. So there's a nice paper, we came up on this recently. Partly I did some work on that when I was a clinical fellow at Stanford, which looks at these different transposition techniques. So the most basic one is really going subcellular extradural. Then you can do the intradural technique. And now much more commonly, depending upon the pathology we would do this through a transcavernous route, which is a way that you utilize the layers between the periosteal and the meningeal dura in order to get there. So this is the way that we go. And particularly if it's something like a chordoma or an extraaxial pathology like a meningioma. And that's the area you're getting into. The problem with doing the other techniques, some of the extradural techniques, is you can. The difficulty is that you can crush the gland, particularly if the posterior clinoids are high. It's quite tricky to get right to the top of it all. Okay, so here is that comparison. You see there, this is an extradural technique. This is your transcavernous technique, where you're coming in through this gap here and you're cutting. If you really want to go high, you can cut this proximal ligament or corticoclinoidal ligament and give you access right to the top of the posterior clinoid. So this is the paper I was talking about, and it's a useful summary of all these different techniques if we are interested, for people who are viewing the webinar and they want more time to read that. And that's the sort of basic technique, where we make that hole in the cavernous sinus, utilizing the layers, cut the ligament, go right to the top of the dorsum, and then resect it. So, for example, this is a surgical demonstration. I'm going to skip that in the interest of time and then go more south, which is the main topic of the webinar. So now, if we come to the mid region, this is where the foramen lacerum becomes important. The reason we go there is if we are trying to go to the prepontine cistern, we are trying to remove diseased bone here in a chordoma or in a chondrosarcoma, or the rare clival meningioma, which is very midline, or if you have a pretty ventral epidermoid. All those are good indications for potentially undertaking these operations. So in this region, we do need to understand the foramen lacerum, because one of the difficulties is when you're doing exposure in real life, it does not look like that. You're limited by the bone around the carotid. And pathologies are often eccentric to one side. So if I have a meningioma or a chordoma or a chondrosarcoma, which is eccentric to one side, really I want to expose the carotid on that side, understand the foramen lacerum, and then have that control and be able to remove the abnormal clival bone as it dips away from you off midline, because then you end up with a much more lateralized exposure, a cleaner exposure. And it's also important for pathology like chordoma, where you want to remove that bit of diseased bone behind the ICA and not leave that. So that is the key, the fundamental thing. The key thing here is to understand the sixth nerve, because sixth nerve is prone to injury in these approaches. This is your cisternal segment. You can see that. This is the so-called, interdural segment in the Dorello's canal. And then it goes right to the top of the petrous apex, paracarotid, and then becomes more distal. So that's the demonstration here. This is more a surgical point that you can use what's called the petrosal process of the sphenoid bone as a localizer in surgery for the sixth nerve, if you are concerned. So that's the bit of bone. So now I'm going to come to the paper that Wei Sin did a tremendous amount of work on, and this is really useful because in order to get to the foramen lacerum, you can do the Trans-Pterygoid approach, but you have to understand some anatomical landmarks to do this safely. And this is important because in surgical cases, the anatomy is distorted. It's not exactly the same. So here, for example, is that bony bit that you see. And the key thing is understanding some of these fissure lines. So your ENT surgeon may undertake the procedure, may open up the maxilla, may drill the pterygoid wedge for you. So here you can see that's been drilled off. Here's the choanal arch. This is your Vidian nerve. But then when you come into the field, you really want to find these fissure lines in order to get into the foramen lacerum. So this is your fissure line here, pterygosphenoidal fissure. And this is quite a nice, useful landmark that you can use in your operations. And what it does is it gets you to the inferior part. It's more useful than the Vidian, I find, because it gets you into the inferior part of the foramen lacerum. You can then Doppler the ICA, and then the lower part of the lacerum is safe because that's all this fibrocartilaginous tissue. So that's your pterygosphenoidal fissure here again, and that's the Vidian, and it's that angle that we are working on. And you can remove that bit of bone in that angle, and then you can enter the lacerum safely down south. And this is, a useful way of getting there. Obviously, more superiorly, the carotid may well be very distorted by the pathology you have, but it's a nice way of finding the carotid inferiorly. And what we do, that's the bony representation. You can see that again. Your Vidian canal is coming this way. There's the Vidian foramen there. And there is your pterygosphenoidal coming to the foramen lacerum. And so that's that representation. Again, that same representation here. This is a triangle that's made by these structures. But the key thing I look for here is once I found the Vidian, I found the fissure, and then I can enter the space. So if you're doing a midclival exposure, oftentimes you would have, if there was a chordoma, sarcoma, or whatever affecting this area here, we would have a Trans-Pterygoid approach on this side. We would work our way, we would expose this segment of the ICA, we would do a midclival exposure, and then on this side, obviously as the flap is destroyed on this side, we would then harvest a flap, and then that can go in the maxilla here or in the nasopharynx if you're not going to the inferior clivus. So it depends upon what surgery you're doing and where exactly you're doing. Sometimes you even need the transmaxillary route from the other side if you're trying to look very medially into the petrous apex. So the idea here is you see the pathology and you plan the approach in a stack-wise fashion. But yes, if we're doing a pure midclival exposure, upper clival exposure, then that's the kind of way we would do that. If you're going more south and you want to go to the sublacerum area, then basically you need to cut these cartilaginous structures, you need to cut this fibroconnective tissue, and then inferolaterally mobilize the eustachian tube. It's often a bit hairy when you do it in surgery. And the idea then is that you're simply opening up this space above and under the foramen lacerum. So let's show you, let's finish that video. That's important to understand that bit of anatomy. This is from, if that plays, otherwise we'll go to the next one. Okay, let's show you some examples. So this is how you start with these approaches. You pick up straightforward cases. This is a lateral recess CSF leak. There are so many ways you can do this open, but we would typically do this endonasally. So there's my ENT surgeon, Warren Bennett, who's come in. So you can see the right-sided maxilla is open. You open the back wall here, and you get into the PPF. So all this drilling is done. You want to safely expose the contents of the PPF, keep the fascia intact. Depending upon if you are doing a schwannoma or some other thing where you need a much more wide exposure of the PPF, we often would sacrifice the internal maxillary artery up front, and that's also quite useful. So here is that opening, and then you are essentially dealing and controlling with the sphenopalatine foramen. And you have nice, again, this is anatomy that's worth reviewing, that you have the sphenoidal process and the orbital process of your palatine bone that you remove. You find your Vidian nerve, and then you start drilling. So this is a fairly straightforward case when it comes to this sort of work and understanding that anatomy. And it's good fun to do these with ENT because they can do the first part and you come in and start drilling. Find the Vidian, and then you cut it. And once you cut the Vidian, the whole lateral recess nicely opens up. You can widen that exposure. You can see you can remove that bone. And the idea of doing that, sometimes people do these without cutting the Vidian, and you can. But the idea here is that you with that wide exposure, you can bring the nasoseptal flap nicely. You can lay it on. You can reduce the meningoencephalocele. And you can see that now I've got a really nice access to the lateral recess here. It's shrunken down to one tiny pinhole that you can see. We put a bit of synthetic material in there, like Duragen or any other substitute you might want to use. That can be tucked in, and then you put your nasoseptal flap on top, which comes from the left-hand side, and that's a bit of glue. So this is a nice way to start with these approaches. Here, for example, now this is a more complex case. So this is a young lady who's got a biopsy-proven chordoma. So you can see here you've got upper clival involvement, you've got mid-clival involvement, you've got a bit of disease behind the carotid. So this is where we plan the approach up front. You need a trans-pterygoid approach. You need to go to the foramen lacerum. You need to skeletonize that right ICA, and then you need to work behind that in order to get the disease. And you can see a post-operative scan here. We've removed all that diseased bone. This is primarily an osseous disease, a little bit of involvement, perhaps a periosteal dura, but there is no intradural disease. So if you look at that, we can see how we applied that anatomy. So again, the maxilla, you can see that has already been opened up on the right-hand side. We're going to do a trans-pterygoid on the right-hand side. This is all the abnormal bone. So now we're going to cut the Vidian. Once we've done that, then you do the drilling, and now we're going to look for those fissure lines that Wei Sin described and what we are doing. And you see how useful it is because you've got a lot of abnormal bone here. You need to be able to find your way through the anatomy. And one of the things I did mention is typically if we are exposing the paraclival ICA, we use the so-called two-point technique. So there is that line. You can see the pterygosphenoidal. It's a nice white line. The Vidian nerve is here. That's your angle. And you can follow that. Typically to expose the paraclival ICA safely, here's the Doppler. We would expose the paraclinoidal ICA at the top. And that's why we do that work over the sella. So this is my middle clinoidectomy. And then we would connect the dots up. It's much easier that way. It's much safer because the depth of the bone there is not always reliable. Okay, so here's the top of the clinoidal ICA there. And then we've got, now you can see we can just connect up those two dots and then use high-speed drill. Coarse diamond is great in order to connect those up. Once you've done that, that's the medial petrous apex. That's our ICA. We shrink the carotid a tiny amount, the adventitia, just to allow access to the bone behind the carotid. Okay, so you can see this is all applied anatomy. Here's my foramen lacerum, mid-clivus. We've removed all the diseased bone. I will peel the diseased dura, and then you go on and then you try your transcavernous transposition here, getting in between the layers in order to, and that's the bleeding from the cavernous sinus. The idea here then is, I'm going to fast forward this. The idea here is that you want to get to the back and remove the bone from the upper clivus as well, or the dorsum, and then we clean up the dura. In these cases where the disease has only gone through or is only in the periosteal layer, I tend to remove the periosteal layer and leave the meningeal layer intact. It's very different if it's breached or if the disease is clearly in the interdural space, in which case I would cut the whole thing out, particularly for chordoma cases. So that's a nice example. And you can see you can use these in different pathologies. So this is one of the cases when we started. Again, this is and actually was thought to be a chordoma, but it's not. It's actually acromegaly. But there's a lot of disease behind the ICA. You can see behind the foramen lacerum. So nice case again to learn your methodology, how to do these. This is mid-clival disease. You can see that this is after resection. We've removed the disease from behind the foramen lacerum and behind the ICA. And just want to show you that, so this case is already planned. Again, we've got the, we start our trans-pterygoid here, find the Vidian nerve, and we try and do the same as you saw in that lateral recess leak case. But you do this all up front before you attack the disease. And the idea here is that what I want is able to get in safely behind the foramen lacerum, and there is the petrous ICA, paraclival ICA, and there's a whole lot of acromegaly disease hiding in that corridor in behind. And the only way you can do that safely, if the carotid lacerum is identified, you can see the carotid is there. I can displace that, put my 2 suction, and then remove all that disease that goes behind so that we can get a clean remission in a young patient. Now, one could argue that's very aggressive surgically. You could treat that medically, and that's fine too. But if you can do that safely, then why not? This is more a more difficult acromegaly case. Again, you can see there's mid-clival disease. There's disease under in the inferior compartment, and this was another lady we were able to put into remission. But similar to that case, you would do a similar kind of exposure. This shows some of the initial steps here. So we do an ethmoidectomy on that side. So this is, first of all, you do a flap. Even though in this case we won't need a flap, we did one because sometimes with the exposed carotid, it's nice to be able to cover that. You do a posterior septectomy. And then the idea is that on the ipsilateral side, we want a nice ethmoidectomy because we want a really good view of the lateral recess because lots and lots of disease is sitting there. So this is all the work that is being done by my ENT team here. And this, the ethmoidectomy. There's a little bit of superior turbinate that's hanging down. And then once we've completed that, then we go ahead and work on the trans-pterygoid approach. So here again, you can see the back wall of the PPF. This is the debriding, and you can see the tumor is very expansile. A nice tip, particularly for the junior residents, fellows, and is that always surround these lumps before you get in. It's very tempting to go in early and get into the tumor and start debulking. But really what you want to do is you want to surgically surround these skull-based tumors before you get in. So now you can see the back wall here, back wall of the maxilla. What we're trying to do is, again, open up and expose the PPF. That's the PPF coming into view. And there, my ENT partner is trying to protect the turbinate, but here I'll end up resecting the lower part in order to get into the, there we go, get into, and once you can cut that and you can stick that up against the skull base, you don't have to sacrifice that. And then what you can do is get in, and here is all the tumor. You can see that now. Now here, we do need to get under the carotid artery. The video gets a bit dark. This is much later. So again, that's the Vidian stump there. That's the foramen lacerum. The carotid has been skeletonized using the anatomy. There is the lower part of that ICA again here, you see. And you can see there is disease that's sitting right around the carotid artery. That's my Doppler. So what we are trying to do here is to remove as much of the tumor as we can off the ICA. And the only way you can do that is if you have that control around the lacerum, you have that control of the carotid artery, and you know what's carotid adventitia and what's not. Oftentimes these tumors are a bit hemorrhagic, but as long as you have planes, you keep working. And you can see that this is the tumor here, the midclival tumor here. Foramen lacerum is to the right of the screen. That's the bit of normal gland. There's a young woman, so we want to protect the gland function. And then we are removing all the bits and bobs of the tumor. Sometimes if it's fibrotic, you can cut that close to the ICA. And then here you see this is a inferior hypophyseal, a meningohypophyseal avulsion. This is not a direct ICA injury, but which you can repair with a bit of fat. Crushed fat is great with a bit of tissue in order to repair these side wall, tiny perforator or hypophyseal, inferior hypophyseal or meningohypophyseal type avulsion injuries. Oftentimes, if you try and coagulate these, you make them bigger, so it's better to do that. So there's now my normal gland. There is the ICA inferior compartment here. This is a bit of fat and tissue. And then we carry on cleaning up the disease from around the foramen lacerum. That's a little bit of nice, clean clival bone. And then we always put a bit of fat around the pituitary gland, only because if she doesn't go into remission, I know she can have radiation and the gland is protected. So that's the reason I don't really use subarachnoid fat, almost always avoid it. And then we bring the nasoseptal flap from the back. So this is from the left-hand side. So this is a great example, for example, of using this sort of approach with in patients with a pathology like acromegaly. Again, I want to show you a couple more cases, and then I'll move us south. This is another pituitary adenoma. Now here you see you've got posterior compartment invasion. There's a disease behind the carotid artery here. And again, you would argue, well, why do you need Trans-Pterygoid? Once again, because you want to be comfortable around that ICA anatomy. You want to know where the lower part is, the top part is, before you resect it. And that's why I would always start, same thing here. We've done our maxillary opening on that side. We are trying to skeletonize the ICA. This is the pituitary gland in the middle here. But what I really want before I tag this case, we've done a Trans-Pterygoid. Now what I'm trying to do is to identify the orientation of the ICA fully in the lateral recess and the paraclival. So here is that middle clinodectomy. You've identified at the top. Again, using the same tips as before, we've got the whole of the paraclival ICA exposed. And then there is that plane with the pituitary gland. And the trick here, that part comes off fairly easily, but then you've got to work around the ICA now. And that's the hard part, because sometimes it's not nice, soft. It can be much more fibrotic and be more difficult to resect. So that's the key here. That's why we bring all these different techniques. So you can see the medial fibrotic wall here. We remove that. I'm trying to peel that wall off the ICA. And you can see it's quite rubbery. That's outside the wall and inside the wall. So you can see disease inside the wall here and then on the other side of the wall. Sometimes if it's very fibrotic, rubbery, in these cases, I would just truncate the wall as close to the ICA as I can and then very aggressively coagulate that. I don't try and force it on the ICA and try and pull it too hard, because the worry would be you cause an injury to the carotid artery. And obviously in these cases, never forget the bits on the easier bits more medially, which can be removed. And this is an example here. There's a little bit of cuff of tumor on the gland that we can remove. And it's important not to forget the easy stuff. So again, this is an example of how Trans-Pterygoid helps you in working in different compartments. So that's the normal gland now. This is the carotid on the right-hand side. This is the final bit of a cuff of tumor or a fibrotic capsule that we would cut and trim down onto the pituitary gland. And the same, you can see the wall is not 100% clean on that side, but we removed majority of the disease. And there is the final sort of view. You can see this is going into the inferior compartment here. That's the bit of, still a little bit of that diseased wall on the ICA that you can tease in part, coagulate. And if it's not coming fully, that's the transcavernous bleed. You can see because you are between the periosteal and meningeal layer. And I think Juan recently described this, that in some cases you get this wall thickening, and you can see there's a bit of disease still hiding beyond the wall. And it's important to do as much as you can. Now you're in that posterior compartment, you're behind the top of the paraclival ICA, and you do as much as you can here safely. And you know you've completed the posterior compartment work because you see the dorsum, you see the lower part of the dorsum sella, and that's the lower part of the dorsum here. That's still a bit of disease there that we peel as much as we can, and that's a bit of fibrotic wall. And again, in amidst that, you will have some soft tumor, as you can see. So it's about being patient and doing this patiently, not trying to rush it, and do the most you can. When you have this kind of wall thickening pattern on the ICA, it's often very, very hard to get a clean removal, and it's about resecting what you can safely from within the cavernous sinus. So this lady did go into remission, but obviously has a high risk of recurrence in the future. So we observe that this kind of disease burden carefully. So this is an acromegaly example, and then want to show you guys a couple of other cases where this is useful. So here now you see this is a patient who's had an operation for functioning tumor where the midline stuff has been resected, but you can see there's a whole lot of disease here hiding under the carotid, in the inferior compartment here. You can see that. And for this, again, similar, following the same formula, we've got a nice opening here. We can see the whole of lateral recess. We've done a trans-pterygoid approach. We are opening up. Again, the key here is to skeletonize that ICA. If you want to work here in the inferior compartment below the paracellular ICA, you really have to skeletonize the whole of the ICA in order to work successfully, because the tumor is hiding in between that periosteal and meningeal layer. So we've come from below, we've found the foramen lacerum. Now we are uniting that from the top. We have to remove a bit more of the dural envelope here because you want to go right out to the V2 in order to work, because we know the disease is under the ICA. So now you can see there is the loop of the clinoidal ICA. This is the previous opening. This is a periosteal layer. We are looking at this in our lab right now now we are coming with that opening up the periosteal layer and coming laterally and down south. So you get that bit of venous bleeding, which is in the cavernous compartment, as you can see. So this is an extension of your kind of medial wall resection, because not only are we removing the disease around here, the medial wall is obviously breached, but you're trying to come under the horizontal paracellular ICA and in front of the paraclival ICA. And you can see there's tons of disease here which is thankfully soft, and we can remove that. But now you have to open up this wall here in front of that vertical ICA. And in order to do that, that right angle knife is very, very useful because you can use that safely. You have to be aware of the sympathetic trunk, which I showed in the previous examples, because you can cause an injury to that and get a Horner syndrome. Also, the other thing that's very useful here is the ICG, and I will show you guys an example of that. So this is the base of the dorsum that we are just cleaning up in order to get in safely in front on that space in front of the paraclival ICA. So key adjunct here. So now you can peel that adventitia. So that's the adventitia around the ICA. And then we can use the ICG. You can see the IC green here. So that's my vertical ICA right there, posterior genu, inferior compartment. And that gives you a bit more confidence in combination with the ICG and the Doppler to resect the tumor. You also got to be aware of the inferior hypophyseal here as you work around the dorsum and the base. So this is an example of how you can use ICG, trans-pterygoid, bring it together for complex adenomas which are involving different cavernous sinus compartment. What about the more other obvious thing people ask about is obviously chondrosarcoma. So I'll show you one more example of how, one or two examples and then stop. So this is a case that we published recently as an operative video, and you see there's a young lady who's got a very calcified chondrosarcoma. This is in the inferior compartment, again, of the cavernous sinus. The carotid is displaced, is narrowed, and there's destruction. This is a heavily calcified mass, which is adherent to the ICA. Okay, so there's a tricky case. So the way we do this, We break the case down into modules. So this is a mid-clival, upper-clival approach with the Trans-Pterygoid as an adjunct to show me the foramen lacerum, because again, the course of the paraclival ICA here is not going to be as normal because it's all displaced. But I want to find the anatomy inferiorly. So you can see this is my ENT surgeon Warren coming in here. And we've done that ethmoidectomy, as you saw. And these cases I've almost shown as we've gone with our learning curve with those some of the acromegaly cases early on. These are some of our more recent cases as we've accumulated experience over 5-6 years. You know, this is not something I would advise doing day one of your practice. So this is my maxilla opened up here. That's a choanal arch, blado-vaginal, and then we find now we're doing a nasoseptal flap on the other side. So here you can see now why those landmarks are important, because I want to find, I'm cutting the video, but I want to find the carotid at the foramen lacerum. Because I know the paraclival ICA is completely distorted by the tumor. It's all displaced laterally, pushed, and I'm not going to get the Doppler signal where it normally would have been. So I go to the top, we perform a middle clinodectomy, and then I come south. So I want to pick up the carotid at 2 different points using the techniques that we discussed. That's my lingual process there, which is the structure lateral to the foramen lacerum. I haven't gotten into that. And then we go to the pituitary here, to the gland. And that's why it's important to understand these in modules. So this is my carotidoclinoidal, this is my proximal ligament. And we divide that. And we do what's called a pituitary transposition here. So you see these are some of the deeper fibers of the carotidoclinoidal ligament. And that's important because all that bone is diseased. So that's all the bone in the dorsum sella that needs to go. And now you can see the exposure. You've got all the diseased bone behind the gland in the dorsum that we're removing. I'm still not high enough, so we can cut that ligament further. And this is the so-called extended transposition, where you're trying to get even higher. And then you get to the top of the disease. And that's the nice thing about this technique. This is another nice trick for these kind of calcified tumors. You can use these side-cutting ultrasonic aspirators, the Spätzle microclaw, which is much more, that's your third nerve, which is much more comfortable when you're around the carotid than something that is oscillating. So here is the removal of all that. And then my traction here, so foramen lacerum is here, Trans-Pterygoid approach, my traction is on the carotid artery, right? My suction, which is protecting that, which is lateralized, and here is all the calcified bits. So now that's the undersurface of the ICA here, you see that. And then we peel the calcified bit from the undersurface of the ICA here, while that suction protects the carotid artery. So that's the ICA here, disease in the inferior compartment. The last bits of disease we are removing, but we still have a bit of disease here. And then ideally what we would do is we would open up that anterior wall of the cavernous sinus. Perhaps one could argue you can open that even a bit earlier in order to remove all this fibroid, all this heavily calcified adherent disease. So that's the carotid pulsation. You can see that's, the lingual process, bits of lingual process being removed, which gives you the access to the anterior wall of the cavernous sinus, and you can remove that. And then you get, you can fully inspect the bed and make sure there's no obvious residual disease. So there's no CSF leak here, but now you can see here's the diaphragm, pituitary, Trans-Pterygoid approach, foramen lacerum, ICA, and then we just put a nasoseptal fascia, a bit of fat, and a nasoseptal flap on top. You don't have to do all those layers here. There's no CSF leak, but in this case we were prepared, so we did that. And you can see here we got a radiological gross total. She still got proton beam in line with the national guidelines. And then you can see that normalization of the carotid anatomy even day one after the surgery, where the carotid looks a bit more normal, like how it should in a person. And then she got, if you're going to the inferior region and below the foramen lacerum, just to quickly finish up on this, again, this is important. This is a nice paper to read, which was done long time ago by Victor Moreira, again in Pittsburgh lab. And there, the difference is the approach is very similar, but you got to do something about this fibrocartilaginous tissue. You have to cut that. You have to displace the eustachian tube inferolaterally, and that opens up. this space around the top of the petroclival fissure and the inferior petrosal sinus. So that's the key extra adjunct that you need. And that saves you having to cut the eustachian tube, because the idea is to preserve that for function. This is a more extreme view, which often surgically we don't see, because most of the time we are dealing with osseous diseases here. But you can see the bulbar nerve here. You can see the hypoglossal nerves here, the top rootlets and the lower rootlets, number 9 here, 10 and 11, and then the 7th, 8th complex here. So where would we use that? So this is an example, again, from early on in my time here in Bristol. And you can see here this man has mid-clival disease. He's got inferior clival disease. He's got disease in the as a brainstem nodule that needs to go. He's in his 70s. This is a chondrosarcoma. And I'll just show you, fast forward this. So we've already done all the hard work. So he had a ossified middle clinoid. So here we can't do the clinoidectomy. So we've used the Vidian. We've already skeletonized the lower part of the ICA here. And you can see I don't have the top landmark. I have the cellar. But once you've got that carotid exposure, then you can remove all that bone on the ICA, which gives you the access to the petrous apex and allows you to remove all this soft. Thankfully, sarcomas are soft, that disease. That's the Vidian stump here, and that we are now cutting that soft cartilaginous tissue below the Vidian nerve, and that opens up the top part of the petroclival fissure, allows you to remove this nodule, and then obviously allows you to work alongside the, you can see the petrous ICA here, allows you to get into that depth above the petrous apex and resect some of the disease. This is a man in 70s, so we're not going to be aggressive here with removing everything, with removing all of the dura. And so that's, this is another case, for example, similar method where we are looking at the disease and planning our approaches in advance. So this is my kind of summary, the way I think about foramen lacerum, trans-pterygoid, and how I plan the approaches, using whether we are going above or below the lacerum and what the adjuncts are going to be. And it also helps with training fellows and training the residents. Other final thing to mention is obviously trigeminal schwannomas. They're great for this sort of approach. Here you can see, you might look at that and go, you'll need a separate approach to get to the top. But actually you can do this all through a trans-pterygoid approach through the PPF. In this sort of cases, we do sacrifice the IMAX on the ipsilateral side, because that injury can cause a lot of problems. And you can see the delayed post-op scan. There's very little residual disease left behind. And just give you guys an idea, again, that's that similar exposure, which hopefully you're familiar by now, that we've done. And there is the medial pterygoid plate. Maxilla is here. We've already ligated the sphenopalatine foramen. And now what we are doing is opening the PPF in conjunction with the drilling within the sphenoid sinus, because you can see it, part of the component of this lesion goes into the goes around the middle fossa dura. So what you're doing is you're effectively imagining it like that, and you're surrounding the whole tumor. And that's the key with these tumors. Don't attack them before you have done the exposure fully. And you can take that exposure quite nice and lateral. It often can be a struggle with the medial maxillectomy to get very lateral, but there are lots of adjuncts you can employ in order to do that. And here, for example, again, now what I want to do is combine that PPF opening with the full Vidian neurectomy and then a lateral recess exposure, because then you've got the exposure along the long axis of the tumor. So this is exposing that area under the V2, and you can see it's all been dilated by the tumor. That's my V2 here. This is all just expanded space. And now I'll complete the work around the foramen lacerum. So again, soft hands, identify the fissure lines, find the lower end of the ICA, and then you've got a safe exposure. You get in and you start your intracapsular debulking. These resections are never very clean when you're doing them, because you have muscle, you have pterygoid muscle. But if you are patient and you just stick with keep with the tumor bed and keep identifying the tumor properly, you will achieve more than you realize, certainly when you look at the postoperative scan. But as you can see, the tumor bed, it's not a clean tumor bed because you always have muscle. So that's our anatomy. Here is our paraclival ICA, lower part, foramen lacerum exposure here, pterygospinodal fissure, V2, and then we've got that connected area here, and we are gently just peeling the tumor. And interestingly, even though you think you won't be able to go high enough, here is now the work around the middle fossa dura. You can actually simply follow the tumor superiorly, and you can get you can remove a lot of the tumor that way. And so you can see the tumor capsule there, here, right there. And so you can track that back, just maintain a bit of gentle traction, and then you can really achieve a much better resection than you think. Because initially when I looked at this case, I thought maybe I need to do a lateral orbitotomy in order to do the top part through a transorbital approach. But actually you managed to achieve most of that through this corridor. So here's that. You can see the dura now bulging. We've removed most of the tumor there. These are the last bits of the tumor going back towards the Meckel's cave, and that's the hole you're left with at the end. But if you go very far back, just remember the parapharyngeal ICA is there, so always have your wits about where you are anatomically when you're doing this kind of work in these areas. So that's a kind of an example, and we can see on the postoperative scan, you can see we've got a majority of the inferior component and quite a bit of that component going towards the Meckel's cave as well. Rarely I would use this for recurrent meningiomas. We're not going to get into this, but unless it's a midline clival meningioma, I don't really use the EEA approach. This is a case with multiple resections through a lateral approach. So here you can use. The difficulty with coming in with this sort of approach is you've got the basilar, you've got the recurrent, the meningioma sitting between the basilar and the ICA, and therefore it makes your life harder. So by and large, unless it's a redo case, difficult case where an open approach is contraindicated, generally use this kind of approach for midline clival meningiomas or epidermoid, rather than eccentrically placed petroclival, where would favor a retroseg or sometimes an apical petrosectomy plus a retromastoid to do the job, rather than big combined petrosal approaches. So that's the kind of philosophy we have used in Bristol in terms of resecting, because you can see it's a corridor. There again is a carotid and the basilar, and you're working in between the two. So in summary, really, the applied anatomy is crucial. Having this paradigm of lab to theatre, theatre to back. And then before you plan the case, when you plan the case, before you get to theatre, look through exactly what adjuncts you need, discuss them in advance with your ENT or another team that you're working with, what exposure you need. And even as a neurosurgeon, have good mastery of the ENT anatomy, because you have to explain to them exactly what you need, and for them to understand some of what you're doing. Work around this supra and sublacerum concept, plan your approaches, because it's very useful endonasally for a whole variety of lesions, and build that 360 perspective of the skull base. This is, my team in Bristol. We've also got a lab that we are running, where now we have PhD fellow working on anatomical projects. And we also run a course. The 5th course will be in March next year, and we'll be announcing the dates soon, which is a sort of a 4 to 5 day course on skull base, with emphasis predominantly on EEA and transorbital and minimally invasive approaches. So thank you for the invitation, and thank you.
Okay, thank you, Kumar. Great talk and a beautiful case. Thank you again. In my opinion, I think the endoscopic transnasal approach is very good for the midline ventral skull base. We all agreed about that, and especially the transclival. So basically, we're talking about this lacerum or cavernous sinus. This surgical landmark is help us to know how to lateral extend, right? Yeah. So to know this anatomy, it really help in real surgery to identify the ICA different segments.
Yes.
Early on, and to try to do the mistake to hit the artery, and to know the limitation, how how we can go laterally. In my institute, because we are in Asia, we have a lot of the nasopharyngeal cancer, so that
Yes.
we do a lot of the case to do this lateral skull-based the lesion, no matter the recurrent tumor or the
Right.
radiation related to complications such as necrosis.
Mhm.
So it really helped to early identify the Lacerum
Yes.
CA. But for my question is, we know that this approach is very good to do the extradural lesion, such as
Yeah.
the chordoma, chondrosarcoma, but
Yeah.
for the kind of the meningioma, it go
Yeah.
interdural.
Yeah.
Even though we know that we can expand a little bit lateral, but it's
Yeah.
very difficult for me to go
Yeah.
to go this approach to control
Yeah.
the surgery. The case you showed in the end, the meningioma case. I think that is a very difficult for me. And what's your opinion?
I think I think the, you know, so I 100% agree with you, and that sometimes happens even with tuberculum cell meningiomas, where you know, at least in my institution, most tuberculum cell meningiomas, we do them endonasally. Sometimes, even if there is some lateral disease, I would do a supraorbital to take it out, just because I find visually you get better outcomes. But I 100% agree with you that, and because it's that reason why, unless it's a very midline clival meningioma with usually a very posterior displacement of the basilar, because you're at the endonasally, you're at the mercy, you know, whichever way you do meningioma, as you know, surgical technique is some of it, but one of the biggest factors is the tumor consistency. And if the tumor consistency is nice, you can get away with a not a very good exposure. And if the tumor consistency is bad or very fibrotic, particularly if it's vascular, then it's very, very difficult, the operation, almost irrespective of the approach. And endonasally, that is amplified even more, because endonasally, as you say, if the consistency is bad, is very firm, particularly if it's vascular, then it's a very, very difficult situation. So I think only in select cases, I agree with you, I would use it for clival meningiomas, and otherwise, where I use the endoscopic work predominantly for meningiomas is, I would say, tuberculum celler and in sphenocaverous meningiomas, where we are trying to do a medial to lateral debulking or optic canal decompression. But for pathology more inferiorly, generally reserve it for softer stuff like sarcoma, epidermoids, and for meningiomas, if there aren't any other options, if they've had disease, a recurrent disease which is very anterior, and they've already had open approaches explored. Yeah.
Okay, thank you. And the other question is interesting, because it's talking about the left side or right side. Because I'm a right-hand surgeon, and so
Yeah.
that for me it's easy to approach the right side, the petrous apex.
That's right.
The
Yeah.
left side is a little bit difficult. Do you have the
Yeah.
same thing or any trick
Yes.
doing the left side?
Yeah, I totally agree. I'm happy when I see the disease around the right carotid, you know, because yes, I totally agree with you. It's easier on the left hand side. Even with the carotid exposure, I find it trickier, because I don't use the non-dominant hand for the exposure. Now, some people use the non-dominant hand, but I'd still try and rotate the right hand to do the exposure on the left hand side. So I find it trickier. Yeah.
Yeah, thank you. Yeah, maybe any audience have the question want to
Not
ask?
so far, but I would like to ask, first of all, let me thank
sure.
Prof. Kumar Abhinav for such a fantastic presentation. We loved
Thank
all
you.
your videos, beautiful dissections. I would like to ask, when the tumor is going like a pituitary lesion, for example, it's going lateral to carotid, what is your experience in using a combined transorbital along with endonasal approach? Do you have any experience in that?
Yeah, so that's a good question. So generally, I mean, I'm still learning with these pituitary conditions, and probably will continue to learn till I retire. But if certainly endoscopically, the main problem, whether you do that transorbitally or whether you do through a standard open approach, doesn't matter. The fundamental technique at the depth is a Hakuba peeling and then getting into so as you know that the main limitation you find is that you've got nerves on the lateral side. So if you come with an open approach, you're basically working between the nerves. Endonasally, if something is in what I call, or what we describe in that paper with Juan, and has been described many times before, if something is in the lateral compartment of the cavernous sinus, in other words, if I find that the acromegaly or Cushing's or whatever is very anterior, it's at the orbital apex, it's around where the nerves are coming together, then generally I just don't attack them surgically, because I feel that the morbidity is too high to the eye nerves, and the risk of ophthalmoparesis is too high. Whereas if it is in any other compartment, certainly the retrogenu, or the superior compartment, I would say is the easiest one to do endonasally. Then I would argue the posterior compartment is next complexity when you're working around the sixth nerve. And where we are in our learning journey is working in the inferior compartment, where the trans-pterygoid is very useful, which is what I showed you in the last couple of videos. And that's where we are getting better, because it takes a bit of confidence to open that dura coming south. You've got to worry about the sixth nerve, the sympathetic trunk. But those are the three compartments I focus on. If I feel that the disease is where all the nerves are coming together, then by that I mean third, 4, and 6 medial to V1 in the lateral and by the orbital apex, then I would tend to leave it. The only times I've gone open for those is where we've gone soft tumor and we've gone through the intradural technique when they've had a redo multiple operations, and endonasally it's a nightmare. And many of those patients already have established ophthalmoparesis. So I counsel them up front. I tell them that, look, I can make your eyes worse, but many of them already have non-functioning eye at that stage. So it depends upon the pathology. If you're doing it for cancer, if you're doing it for more difficult, then obviously you can even cut the nerves, you can exenterate the sinus, you can do a balloon test occlusion, you can do all sorts of things. But for pituitaries, by and large, I do, 99.9% through the endonasal corridor. Where we do use, where I have used the orbital corridor is more where if I've had difficulty with a cisternal segment that I can't bring down or something like that, or a giant adenoma, those kind of things where I've hybridized it sometimes.
Right, thank you. Another question is that recently, like you said, like you showed also, many cases of pituitary transpositions. And I have often noted that whenever this procedure is done, at the end of the surgery, the gland becomes extremely congested and red due to the retractions. So how much of function would we expect in such cases in the postoperative period?
Yeah. So so that lady, for example, had no. So I think if you're doing the transposition, Wayson can tell what his experience is. But my feeling is that if you do the transcavernous way, which is not what we do every day, obviously, but my feeling is that if you do it on one side, even both sides, you don't lose the anterior gland function. Anterior gland function, if you lose that, that's more handling and damage in other ways. Majority of times, what you're worried about is the diabetes insipidus and getting the posterior gland dysfunction. Now, most patients where I haven't had anybody get permanent DI as a result of transposition, transcavernous technique, but I have had patients get temporary DI that sometimes has lasted 2-3 months, and the dosages have come down over a period of time. So I think the DI is well described in relation to pituitary transposition, and I personally think that the transcavernous technique is reasonably kind to the gland. Sometimes where I've done it intradurally, I find those are the cases where you can end up handling gland even more, like for craniopharyngiomas and things like that. But you're absolutely right to worry about that. It can happen. You can, and it's a combination of handling. It's a combination of venous drainage outflow disruption. But like I say, what I worry about is DI rather than losing the anterior gland function.
What is your experience, Dr. Vaisen?
If you really do the very classic transposition, of course, you in the end the gland, as you say, that it will be it look very congested. But so you really rely on the pathology while you do the transposition. Yeah. So in my experience, probably a few the craniopharyngioma go extend to the dorsum sella, and I have to, or interpedunculated cistern, the part I have to do this kind of the transposition things. For the majority of the pituitary tumor, it's not necessary, or the gland already away from the it's not like the typical position, original position. The gland will be there. So I agree that I try to preserve the stalk with the connection to the posterior gland and try not to have the post-op the DI, permanent DI, and the anterior gland just depend on how delicate you dissect or you push this and so it for me the recent case I did, the patient all the function was preserved. It still work, for this technique, but that's the case is look like the Rossi cyst. In the end, we found that the pathology is just some mucus inside. So we just try to make sure every compartment we already exposed. So that was a limited the manipulate of the gland. So that's my limited experience.
Thank you very much for your very nice comments. So we can wind this up now. You can say your concluding remarks.
It's really my honor to join this webinar. Thank you, Kumar, and thank you.
Thank you. Let's see you soon, hopefully in person, Vaisen. Thank you for the invitation. Thank you very much.
Yes.
Thank you very much. I'll close this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I'd like to thank both the speakers of today, Dr. Antonio Ieva and Dr. Kumar Abhinav, as well as the chairs, Dr. Gleb Danilov and Dr. Vaisen Wang, for the time and support for the ACNS webinars. A special thanks to Prof. Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have around 250 live audiences today to watch this webinar. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.